Hello, everybody. My name is Guillermo Garcia-Manero from MD Anderson Cancer Center in Houston. I'm very happy to be here today at the ASH meeting in San Diego. We're going to be discussing topics related to myelodysplastic syndrome.
Hi, I'm Jamie Koprivnikar. I'm from the John Theurer Cancer Center at Hackensack University Medical Center. It's a pleasure to be here today.
I'm George Yaghmour. I'm the Associate Director of the Transplant Program at USC Los Angeles. Genuinely honored to join you today for this discussion.
I'm Sangeetha Venugopal from the Sylvester Cancer Center, University of Miami.
To close, you are also a transplanter. I'm not. I don't know if Jamie does.
I don't do any transplants.
But this is something that, I think it was Sangeetha was talking about how this IPSSM has kind of resulted in this upstaging of some of these lower risk patients into intermediate high. We've never transplanted lower risk patients. Indeed, the American Society of Stem Cell Transplantation doesn't recommend it. But do you see that all these kind of changes will maybe find a niche or a role for early transplant in patients with low risk MDS?
Very great question that I have to answer at least 2-3 times a week in my clinic. Yesterday I had a discussion with my patient and team, and yes, we have a data that's still, controversial based on, if you have low risk MDS, and we know those patient population always older age, carry comorbidity, and there is non-relapse mortality up to 30% from the transplant. That the focus is the overall survival. Knowing from CIBMTR data that said overall survival from transplant outcome using non-myeloablative and reduced intensity that has improved the overall survival. And commenting on the ASH data that if we use the molecular scoring system, we observed that patients who were on the intermediate risk by IPSS, 20% of them benefited by overall survival by delaying transplant, having with additional information, still 19%, if they transplanted earlier on that data, they got the survival benefit. So that would tell us, of course, if we have more molecular mutation data that we see with our patient population, including not just P53 mutation, because deletion 5q now we know there is a data showing us there is a new way to categorize those patients, 5q with P53 or without P53, regardless of the blast count. In my opinion, as a transplanter that I do over 30 transplants a year at least, and I tell my patient based on the overall scoring system and the donor availability that if you do the using don't include the molecular mutation, and basically they are not in the very low and they are in the intermediate risk and having those bad player mutation, offering allotransplant, which is remain the only cure with non-relapse mortality. If you have a good match donor in the setting of using T-cells depletion, you have survival benefit for this patient population. But if they don't carry that scoring, that would make us talking about those 20% patients that will have better survival if you don't do the transplant. And the time of transplant matters sometimes for this case. It remains a controversy, and based on the institution survival data and patient preference and comorbidity, still would like to have more confirmatory data.
Wonderful.